Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hi, and welcome to Conversations with CEI. My name is Lauren Walker, and I direct CEI's Hepatitis C and Drug User Health Center of Excellence. Today, we'll be talking about cannabis, specifically cannabis and pregnancy. Use is trending upwards among New Yorkers of childbearing potential, but we don't have much evidence on its impact on pregnancy, birth outcomes, and health overall. And clinical recommendations for patients who use cannabis during pregnancy are even harder to find. Today, we'll talk through the evidence that does exist and provide best practices for caring for pregnant persons who use cannabis. I am joined by two esteemed guests, Dr. Lynn Porodnik, a physician with over 20 years' experience who operates a sole practice in Westchester. She is one of the leading medical marijuana clinicians in New York State who advocates for cannabis education and the expansion of New York's Compassionate Care program, which we'll hear about later. I'm also joined here by Jamie Lewis, a Haitian-American public health practitioner with over 15 years of education and experience. She is currently serving as cannabis program manager for the New York State Department of Health. All right. Hello. Welcome, both of you. Thank you again for joining Conversations with CEI. How are your days going?
I'm doing well. How are you? It's a gloomy but productive Thursday.
I'll take that.
And a bit chilly. I'm ready for that spring.
We'll put in a good word. Jamie, I'd like to start with you, and I'm hoping you can help lay a little bit of groundwork for today's conversation, set the scene for why this is important and why providers should care about medical marijuana and cannabis.
Yeah, sure. So here in the Department of Health, we really look at cannabis to understand the impact of cannabis use on New Yorkers. And as part of understanding that and informing the work, we do a lot of data collection from clinical sources and surveys to get a better sense of what that looks like. And what we saw through data collected from 2016 to 2022 is that cannabis is one of the most commonly used substances during pregnancy in the United States. And there is potential negative health outcomes for cannabis consumption during that period. And so we've also done a survey through our pregnancy risk assessment and monitoring system to get a sense of the prevalence of cannabis consumption during the perinatal period, as well as to better understand clinicians' screening and advising practices around this. And what we have seen is in the time period mentioned that the use of cannabis before pregnancy, during pregnancy, and after pregnancy have increased from 2017 to 2022. But then we've also seen that there have been very slight increases. So we only see about 2/3 of providers even ask about cannabis consumption during the perinatal period. But also beyond screening, we see around a quarter to a third of providers actually advise around cannabis consumption. Putting all of that together, seeing that, again, this is one of the most commonly used substances during pregnancy, knowing that there are potential negative impacts on the baby, but also seeing that gap in how often providers are actually screening and advising, this would be a great opportunity to kind of fill that gap, provide education and guidance on why it's important in more depth, but also some tips on and guidelines on best practices for that for providers.
Thanks so much. Lynn, I'm curious how that sits with you, hearing some of these numbers about low screening, given that you yourself began your career as an OBGYN and have now transitioned to a medical marijuana provider.
Well, I think it's really important that the clinician has a relationship with the patient. In prenatal care, you have to, as a physician, you have to be trusted. And cannabis is actually the most used federally illicit drug, according to ACOG. And it's common, it's out there. You walk on the streets, you smell pot in New York City. However, women use it for all kinds of conditions. And it behooves us to really extract out why are people consuming cannabis. Let's start from the beginning. Women who are on SSRIs, SNRIs are often told, stop, it's harmful for your baby. So what do they do if they're climbing the walls? What do you do if you have 3 kids at home, you barely can scrape together dinner, and you're pregnant and you feel trapped? Cannabis is a nice relaxant. The most common use in pregnancy is anxiety and depression. People also complain of pain, weight gain. So we really need to sit down and find out what is going on, but not in a negative way, not an interrogation, but in an understanding way. When I meet patients, I have a table and on there I have vape pens, I have bud. I just make it, this is the world we live in, and it's acceptable and it's okay and it can be helpful. But in pregnancy, we look at outcomes as well. IUGR, intrauterine growth retardation, low birth weight, NICU admissions, developmental delays. These are all sequelae from too much cannabis use in pregnancy. But why is the patient using cannabis to start with?
So it sounds like you start by just normalizing this is something that exists in our world. It's not scary. And as a provider, hopefully you have seen it. So let's talk about it openly on the table. And I would imagine that's a great first step in making someone feel comfortable and safe and wanted in your clinic. Do you have any other strategies that you can share about highlighting the principles of harm reduction, why that is so important when working with pregnant people who use cannabis?
It's so important because, first of all, on the street, we still have a lot of tainted products. Women who are coming in and using cannabis, often they can't afford to buy what they feel they can't afford to buy, the cannabis that's in dispensaries. So the street is what they're used to, and they call their guy and he brings it. But there's still fentanyl in products. Also, women who are on methadone or using heroin, cannabis can take away cravings. So I much prefer my patients with cannabinoids than inject heroin. So we really have to look at this from all views. What's best for the patient? What's going to be the best outcome for the child? And also, it's really important dosing and sequelae really depend on how much is a patient using. When a pregnant woman's blood is taken, and if you compare how much gets to the fetus, it's estimated at about 10%. So not good, but at least it's not the equivalent.
But then the potency of the cannabis used would certainly have an impact on what is being received by the fetus.
Absolutely. Potency and frequency. It's a whole package. And we really have to dissect out, okay, what are you doing? Why? How can we reduce it? And I have no problem talking with patients about, okay, instead of 4 times a day, how about we try 3? And when they come back again, how is the 3 times a day program working? Do you think you can do 2? Just trying to make consumption a little less.
And would you have recommendations then also for the way that the substance is ingested? I am not a clinician, for those who don't know me, but imagine that smoking is more troublesome than potentially an edible or vaping.
Absolutely. Also, tincture can be helpful. Tincture lasts longer than the vaping and smoking. So I can often convince women, you know what? Why don't you use this? You can mix it in a high-fat food like Nutella, peanut butter, avocado. So it's kind of sounds healthier, but it will last a little longer and you're not going to impact your lungs. Edibles also, but the problem with the edibles is they hang around a lot longer. Does a patient really need to have that potency going on for 6, 7, 8 hours? Also, sometimes they're waiting for it to kick in and they're anxious. So they'll kind of have a hit or 2 on the vape pen prior so they can sync their edible. And in pregnancy, we rather try one thing and minimize as much as possible.
Jamie, anything to add to that conversation?
Yeah, I do want to piggyback off something that was said about really setting the foundation for that conversation by really having a relationship and connecting with the patient and understanding why they're using cannabis, and which also ties into benefits of buying from the legal market. Oftentimes, when patients are buying from a local supplier that's not licensed, they are often maybe trying to self-medicate, whether it's pain management, nausea, whatever the case is. With the legal market, yes, you can get that advice on site from a pharmacy or clinician, but also you can get the education. There are certain things for which an individual might learn that they don't need intoxicating cannabis, and they may use something that has more CBD than THC, to where this harm reduction, it doesn't necessarily eliminate all the risk, but you get more nuances and understanding the options you have to manage whatever specific reason it is that you might be using cannabis at this point. but also understanding harm reduction still has its place because there are some people that are using it recreationally. And like was stated earlier, even if it's getting the person to reduce their intake, it's incredibly helpful.
I'm curious if either of you have any idea or stories potentially from your experience of how use has changed over time or stigma around use, just with the proliferation of these new products that are on the market. What impact are you seeing that have on the patients that come through your doors?
I see that patients are kind of finding this, oh, it's the norm. Like having cannabis around is the norm. They're not seeing it as medicine. It's kind of, this is what they do, this is what they're used to. However, if you get a little bit of peer support, sometimes you can make a difference. In the ACOG guidelines, they really go through how you try to get peers to tell patients, you know what, not a good idea for your baby. I want to babysit your child. I want to spend time with your family. But if your kid is like a little not there, I don't want to be included. So you can really, through family networking, through peer review, you can make a difference. And that's really not a common strategy.
I'm going to switch gears a little bit here and take us back to an earlier part in our conversation, but just curious what the next steps would be. So a pregnant person comes to you and discloses, I'm using cannabis. You have some of the conversations with that person that you've had with Jamie and I today. How does care kind of unfold from that point? Does it differ at all because the person is using cannabis, or is it just standard of care?
In my practice, it's part of taking care of somebody. I'm not doing straight OBGYN anymore. I'm just doing cannabis only. So my experiences are going to be a little bit different, but I do get patients coming in who are pregnant. I get referrals from psychiatrists, and they're super concerned. Oh my God, this woman is ruining her life by being an unwed mother, possibly a minority person. And so there's two factors involved. There's, as a Black or Latina woman, your odds are 4 to 5% higher of being somebody testing your urine and deciding, oh, there's cannabinoids. Let's call Child Protective Services. Let's look at this as a criminal way instead of saying, okay, take a step back. This is a patient. She has needs. Let's address her needs, not worry about all this back and forth.
Talking about the disproportionate risks some individuals face for their cannabis being reported. And so I do want it to just, as a reminder, there is no requirement that providers report cannabis use, any law enforcement agency or child protective services. Now, I understand the concerns because the laws have changed and there are some cases in which clinicians do report drug use. But in terms of cannabis use here in New York State and elsewhere, there is no requirement that clinicians report it. And so individuals should not feel worried about that in terms of disclosing cannabis use to their provider. And so that's just to put that out there, both as a reminder to providers as well as to patients.
Do either of you have resources or any key best practices that you would share with colleagues or patients that we might be able to help distribute to folks who are listening today?
I would say look at the ACOG guidelines. They're very simple. October 2026, ACOG put out a very nice paper, and it includes a lot of information, and it's readable, and there are nice little clips in there. And also, it would make a patient feel you're respecting them, not giving them keys to the Mickey Mouse Club. Because if you treat people like dummies, they're going to act like dummies. If you treat them as an educated person, going to have a baby, going to launch a person in this world, it's a different conversation.
Yeah, and I'll also add some of the information I mentioned earlier was referenced from the Pregnancy Risk Assessment and Monitoring System. So on the Department of Health website, there's a cannabis webpage that links to that report, where we also include recommendations to improve prenatal care providers' awareness, assessment of, and education on cannabis consumption during pregnancy and chest feeding. And in addition to that, I would also recommend there is a therapeutic guide to medical cannabis in New York State that the Department of Health has also developed, and it provides a lot of more detailed information for clinicians that might be interested about the pharmacology of cannabis, dosing guidelines, documenting and screening practices, etc. And I think that would also be a really great resources for providers who are curious to have those more in-depth conversations with their patients.
Awesome.
And they're good. I reviewed them and I like them.
Awesome.
Seal of approval.
Absolutely.
We'll be sure to link those resources for you listeners in the podcast details. And I would also be remiss not to plug CEI's existing webinar. It's available on our website, and that is on clinical cannabis. So again, goes through pharmacology, dosing, some of the baseline information that you might need if you're starting to consider this as a future for your practice. Jamie, what else is the Department of Health doing around medical marijuana, and how are you collaborating with others across the agency organization to get things done?
Yeah, so just for context, in New York State, when it comes to the legalization of cannabis, we have a few different agencies that kind of have different roles. And so we have our colleagues at the Office of Cannabis Management. They do a lot of work as it relates to licensing, regulation, enforcement, but they do also have a public health office within their agency. Here at the Department of Health, our focus is largely on public health, public safety, and research. And so we work together with other agencies like the Office of Addiction Supports and Services, the Office of Mental Health, and our focus is in terms of for families and safety to do a lot more work to prevent unintentional cannabis consumption through safe storage campaigns. We develop campaigns that are focused at what we consider priority populations. And so women and individuals in this perinatal periods, that is part of it, and providing more education and resources for people in this point, providers as well. But then we also do work in terms of making sure that we're fostering equity and access to healthcare. We mentioned earlier that sometimes there are distinct, different experiences that whether it's people who are of color, whether it is veterans, whether it's young people, that there are distinct challenges that they may face, whether it is in impacting with the legal justice system, whether it is in access to medical cannabis. And so we want to support and foster equity in that space as well.
Lynn, anything to add? Any resources or tips that you typically share with folks?
Google, look through. ProjectCBD.com has a lot of nice information. It's very easy to read. Justin Sulak is a provider in Maine who has his own line of products, but he has very good information on his website as well.
Wonderful. I feel like we're kind of wrapping up the conversation, and I want to give each of you a chance to share 3 additional things that you wish everybody knew about cannabis use during pregnancy. Jamie, let's start with you.
One thing I want to start with, because here we really like to focus on harm reduction, meeting people where they are. And so this is mentioned in the ACOG guidelines that, again, we're well aware of the risk of cannabis use during pregnancy, and we do recommend against it. That being said, in the most recent guidelines, people should take note of the fact that it is still recommended that women or individuals continue to breastfeed or chest feed despite. And so again, we're still learning a lot about how cannabis use during this period can impact a child, but we do know a lot about the benefits of breastfeeding and what both mother and child derive from that. And so we do want to continue that. One other thing is I would like all providers to know whether or not you are a certifying clinician, meaning that you are certified by the state to certify patients for medical cannabis use, that the state has a lot of resources. We want all clinicians, whether you're certifying patients or not, to be educated on cannabis and to be able to talk to their patients about it. And so I would highly encourage them to, again, check out those therapeutic guidelines that I mentioned. But the Office of Cannabis Management also has a cannabis education library that just has a comprehensive repository of resources. And so I'd mention that. And then the last thing I would say, again, for individuals who are using cannabis, tying back to harm reduction, I would encourage, if you choose to use cannabis, I always encourage individuals to buy legal. The New York market space is expanding. We have medical dispensaries as well as adult use dispensaries. There are a lot more formulation types from the medical dispensaries. And so if you don't want to smoke or vape, you have tablets, chewables, etc. but it's the peace of mind of not having to worry about any contaminants in your product, that it is tested, that it is well labeled. And I know there are lots of concerns about, cannabis, fentanyl in the drug supply, et cetera. While there is no evidence that fentanyl is being added to cannabis products, and there's not been any lab testing that's confirmed credible evidence of fentanyl-laced cannabis, it is always better safe than sorry. And there are other risks of contaminations other than just fentanyl. And so I encourage everyone, if you choose to at least buy legal.
I love that. And I know what you mean. Like we hear contaminant and we immediately think fentanyl. And there are so many other analogs and substances and precursors that could be in there, whether or not they are even intended to cause euphoria or really do anything. So I second your third point. Thank you, Jamie. And Dr. Prodnick, up next, what are your top 3 things?
Well, I love what Jamie said. She kind of took the thunder out of that question.
I'm sorry.
No, it's all good. Something I really like people to really get is that in the ACOG, there's another ACOG paper that talks about breastfeeding and cannabis and the fact that if people are smoking postpartum, okay, wait 2 hours before you breastfeed your child, or don't give the child breast milk until 2 hours after the cannabis that's for smoke. They don't get into other options, but just the idea that, okay, you're doing this, we get it, it's okay, it's not what we would call medically acceptable, but you need this, so that's fine. But be smart about it. Keep your child as healthy as possible. And I think that's a little tidbit that gets lost all the time. Pace yourself. Use a breast pump. There are modalities out there that can reduce the baby's intake. I think that's really important. You see play groups and stuff. The mother has a joint in one hand, the baby's sucking her breast in the other, and they think this is cool and groovy and all natural. Guess what? You have to think again. Wait, this is not the time and place to be doing this. Also, because cannabis is so widely acceptable now socially, people don't think of it as a drug. And we still have to think of, although it's plant derived, the side effects are a lot less than big pharma drugs, but think twice because you're working with the drug.
Love that. Thank you so much to both of you.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.